morning, and welcome to the Trauma and its Impact on Behavioral Health Concerns in Primary Care conference call. My name is Anera, and I'll be the operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star, then 1 on your touch-tone phone. I will now turn the call over to Ms. Julie Schmelzer. Julie, you may begin.
Thank you, and good afternoon, everyone. My name is Julie Schmelzer, Project Specialist at Metastar, and I would like to welcome you to today's webinar called Trauma and its Impact on Behavioral Health Concerns in Primary Care, presented by Lake Superior Quality Innovation Network, or LSQIN. The LSQIN is comprised of 3 organizations: MPRO in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement. First of all, thank you for joining the presentation today. This session is being recorded and will be available in approximately 2 weeks on the LSQIN website YouTube channel. Now, because we are providing continuing education credit for this presentation, we need to inform you of a few items. First of all, no commercial support has been received for this learning activity. The speakers and planners have reported no conflicts of interest. For CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation. We encourage everyone to complete the evaluation to provide feedback on the session. An email with an evaluation link will be sent at the conclusion of the webinar to the registration email you indicated. Participants in a group setting should submit a list of who participated with email addresses included to continuing-ed@metastar.com. So today we are pleased to have Mia Croyle present on our webinar. Mia is a behavioral health project specialist with Metastar, which represents Wisconsin and the Lake Superior Quality Innovation Network. Trained as a clinical mental health counselor, Mia has worked in a variety of behavioral health and primary care settings. She has spent the past 10 years working on the integration of behavioral health into primary care settings. Her primary focus is on healthcare communication, and she is a sought-after trainer in motivational interviewing, which is an evidence-based communication style to facilitate behavior change. She has a Master's of Arts degree in Clinical Mental Health Counseling from Valparaiso University. Our second presenter, John Glover, is not able to join us today unexpectedly. So at this time, it is my pleasure to turn the presentation over to Mia Croyle.
Thank you, Julie, and thank all of you for joining us. I know some of you, this is your lunch hour. Some of you were just in that post-lunch time. So thank you for joining on. And we're going to spend the next hour or so thinking together a little bit about trauma and how that may impact both behavioral health and what you see primarily in primary care. So the main objectives for this webinar are to examine the wide range of adverse experiences that could cause trauma reactions. We're going to talk a little bit about how trauma impacts memory, a person's capacity for regulating their emotional state, and also their behavior, learning, and health. We're going to look at the link between trauma and behavioral health conditions. And then, most importantly, from my point of view, we're going to look at some ways that you can increase your own sensitivity and responsiveness to individuals who have experienced trauma. Before we jump into the content, I want you to just think for a minute with me about this little girl. If you saw this little girl on the street, what would your feelings be around helping her? How far out of your way would you go to give her a hand? She was walking down the side of the road unaccompanied, like we see her in this picture. You know, what would you want to do or say to her? How would you feel about her? And how would you feel about her if she showed up and presented for care in your setting? Now I want you to think about this girl. If you saw her walking down the street unaccompanied, how would you feel about her? How compelled would you be to reach out and help her? If she presented for care in your setting, how eager would you be to meet her needs, and how far out of your way would you go to help her have her needs met? And lastly, this woman. If you saw her on the side of the road, how far out of your way would you go to help her, to help meet her needs? If she presented for care in your setting, how would you feel about providing care to her? How would you respond? And how far out of your way might you go to make sure that her needs are met and her care is provided for? So we're going to look at some different definitions around trauma and define some of the important concepts. So first of all, it's important to know that at its basis, any trauma response is basically a biological stress response. So when our body senses some danger, that stress response gets triggered. So we perceive something to be a threat, and we get triggered in some way. What that does to our body is our nervous system gets activated, right? So we get into a state of high alert. Our thoughts are not as clear. We might have really extreme thoughts like, I should get up and run away. We become hypervigilant. So that means like really paying attention, scanning your environment, paying close attention, and being really on the lookout for additional threats. We focus in and really zero in on that perceived threat, and we feel on a very biological level a drive to do something. So we commonly hear about this fight, flight, or freeze reaction. So some people and some situations really trigger people to get in a very aggressive or other type of stance. And some situations and some people, when they perceive a threat, they get very compelled to leave. So they get kind of a little bit like a caged animal if they're not allowed to find an outlet or a way to escape the situation. If you think about this on a very biological level and think back to, our species history, this allowed us to survive. So if we were out on a prairie or on the savannah and we perceived a threat, we have to either arm ourselves to fight that threat or get ourselves out of the way of that threat. And that survival mechanism really served us well. Now, when we talk about a traumatic stress response, that's when we respond with the stress response in a prolonged or severe or recurring type of way. So what happens is this stress response can become a chronic state of being. Now, this may be because the stressor is a chronic condition, something that doesn't go away. Our living environment is unsafe, and those stresses are there day in and day out. Or it may be because something in our system continues to bring that threat up to us. It's not resolved in any way, and so we continue to experience it. And what we know is that prolonged stress response can lead to permanent changes in our brain and in our body. So things get impacted in terms of how we learn, how we remember things. And that has a very strong response, and we're still learning about all the ways that it impacts our body. Some of the latest research that's coming out has shown that even impacts our DNA. So down to a very genetic and cellular level, that prolonged stress can really have a deep impact. And if we think about it, if it's impacting our DNA and our genetics, that can have a generational impact as well. We know that this traumatic stress can impact our relationships, our personality, our health, our well-being, our sense of self, and really every aspect of someone's life. So some of those common traumatic stress responses are that we may re-experience the stress over and over again. We may have recurrent memories that we're unable to block out, intrusive thoughts, many different nightmares or dreams, various ways that we continue to experience that stressor over and over. We may respond by becoming hyper-aroused, and what that means is like we're just on high alert all the time. We may avoid certain things, certain experiences, certain people, certain sets of circumstances because we are in that stress response. And we may become preoccupied with that. So these intrusive thoughts, intrusive memories, and really it becomes our focus. So we talked about in that acute stress response, right? If I'm on the savannah and I notice a tiger across the room, I need to focus on that threat. But when the acute stressor is no longer there and I'm continuing to only focus on that threat, that's when it can become problematic, that response. So when we think about defining trauma, sometimes you may hear people talk about trauma with a big T and trauma with a little t, or capital T trauma. So capital T trauma is, we look for these 3 E's to be present. So there's got to be some precipitating event. Could be also a series of events or a set of circumstances. And that that we think about one set of circumstances might be, growing up in a very unsafe neighborhood where there's a lot of violence, guns, etc. That's a set of circumstances. Another set of circumstances could be a military deployment, where it's not like one particular battle that was the event that triggered the trauma, but that set of circumstances together may comprise the event. So there has to be some identified event, and the person, the individual, experiences that event as physical or emotionally threatening. So generally, we find that our integrity, both our bodily integrity or our integrity as a person, is threatened by the events that cause trauma. An important part of that is that it is somewhat subjective to the individual's experience. So people sometimes wonder, how can 2 different people go through the same experience and yet have very different responses? One may have very complicated and intense trauma reactions, and one may respond very differently and not show the same significant response. And part of that is because it is individualized in terms of your perception of the event. And then the third E for the 3 E's in trauma is that we have to see some lasting negative effects on that person's functioning and on their well-being. And well-being can be defined in a bunch of different arenas, that mental, physical, social, emotional, spiritual well-being, or all of the above. So I've already alluded to this a little bit, but there's a variety of different types of trauma, and this slide doesn't even cover half of them, but these are some of the most common ones that we see and that we hear and discuss. So there's acute trauma. That may be exposure to a single overwhelming event. We think about the examples of the unfortunate examples in our society of mass shooting events. If you were involved in that, that would be acute trauma resulting from that event where you felt that your life was threatened because you had some connection to the location, you were there, you could have been there, a variety of different things. But sort of a single event tends to be considered acute trauma. Complex trauma is often what we talk about when we talk about childhood trauma because it's extended exposure to some type of traumatizing situation. We're going to talk about adverse childhood events a little bit later in the presentation. But these are very complicated to resolve, partially because they happen alongside developmental milestones. So if you think about trauma that happens to younger individuals, they're still growing and developing as people. Their bodies are still growing and developing. And so that complex trauma that often is extended and repeated and just a chronic condition of their life, they develop with that sort of intertwined into their being. Then we often talk about secondary trauma or vicarious trauma, and that is the stress and the response to the stress that comes from helping or wanting to help someone else who is suffering or traumatized in some way. And then it's important to know we often talk about PTSD or post-traumatic stress disorder, and that is a specific mental health condition that is triggered by trauma. There's specific criteria that need to be met as a condition to qualify for post-traumatic stress disorder, and a lot of those are some of the things that we've talked about already. But just because someone has some trauma response, it doesn't all fall into the category of post-traumatic stress disorder. Another important concept or definition is re-traumatization. So this is when an individual has a conscious or unconscious reminder of past trauma. And what happens then is that they, in their body, and sometimes in their memory as well, re-experience that initial trauma event. So an example of that may be, an individual who has had some early life sexual abuse may find medical exams to be very re-traumatizing, and they may have a very conscious understanding of why that's the case, or they may just sort of have this understanding of, I don't like to take my clothes off when I go to the doctor, and I don't like them touching me. That does not feel safe to me. We know that re-traumatization can be triggered by a particular situation, like I said, or an environment that replicates the dynamics of the original trauma. And so sometimes those dynamics, very frequently when we're in a situation that's going to trigger trauma, that involves a loss of control, a loss of power, and a loss of sense of safety. So it may be that nothing else is similar except the person feels very vulnerable, they feel like they're not in control, not in a place of power, and that they don't have that safety. That may be the only similarity in the situation or the circumstance from the trauma that they experienced earlier, and that in and of itself may trigger a re-traumatization for them. And talking about triggers, right? So triggers are, because our brains are so good at remembering things that are unsafe. If you think about it, again, going back to, if I'm in the savannah and I eat some berries and they make me very sick, I'm likely to remember where those berries are and what those berries are. My brain is much more likely to remember that than any other, day-to-day experiences, or it's actually even more likely to remember where the poison is or the berries that made me sick are versus the berries that are super delicious that I really loved and were very sweet and very ripe. So our brains do this great job of remembering things that were clues that there's danger coming. And unfortunately, those then become our triggers. So they tell our body, hey, danger might be coming. Get ready. And our body is trying, we're trying to keep ourselves safe. And so we have a response when we experience those triggers. And all of this may happen without a conscious awareness at all. That varies from person to person, but the person may not know why they all of a sudden feel really antsy and anxious when they're sitting in the doctor's waiting room, or they may have a good understanding of that. And it's important to remember that this response of getting triggered by these things is in the service of survival. We're trying to keep ourselves safe. And so it's not that we're trying to be difficult. The resilience is also a very important concept when we talk about trauma. We also want to talk about resilience. So resilience is the capacity that people have to cope with and adapt to these traumatic and adverse experiences. Resilience, to some degree, explains why some people experience trauma and have more negative outcomes from it than others. We also know that so resilience is where we sort of get back to our baseline. So this is where we can either establish or return to a sense of psychological security and typical functioning. So we know that growth and healing in a post-traumatic situation are very possible. That doesn't mean that it's every individual's responsibility to heal themselves. So it's important that we recognize that resilience is built on somewhat our individual resources, personality, that growth mindset we hear people talk about, but it's also very dependent on social, cultural, and actually tangible physical resources that are available to people. We're going to shift gears a little bit and talk about adverse childhood experiences and the ACE study. So the ACE study was conducted in the mid-90s, the original study, and it was done, a physician at Kaiser Permanente in California wanted to look at childhood experiences and then their current health status. So they took members who were in the HMO, the Kaiser Permanente HMO, and they surveyed them. When they received a physical that year, then they got a confidential survey that asked them about childhood experiences and also asked them about their health status and some of their health-related behaviors. And it's important to note that these were generally upper middle class, white people who were employed, who had insurance through an employer. So these are, folks that we think, based on some social determinants of health, should be doing fairly well. So the categories that they asked them about, that they looked at in terms of past adverse events, was physical, sexual, verbal abuse, also physical and emotional neglect. They looked at whether there was an adult family member who was depressed or diagnosed with other mental illness or experiencing addiction. And they also looked at incarceration of an adult family member. They looked at witnessing a mother being abused in the home, losing a parent to separation, divorce, or other reasons. Military deployment could be there as well. So those are the original categories. Some new categories that have been added in the years since and other things that different surveys have looked at is experiences of racism, gender discrimination, witnessing a sibling being abused, witnessing violence outside the home or in the community, witnessing a father being abused by a mother, experiencing bullying by either a peer or an adult, being involved in a foster care system, living in a war zone or an unsafe neighborhood, and losing a family member to deportation. So when they looked at this original ACEs, the original study found that approximately 65%, or 2/3 of the population they surveyed, had experienced at least one adverse childhood event. So if you think about that, I like to take that and try and translate that into like, what might I be seeing in the clinic, right? So for every 100 patients you see, about 35 of them have had none of those adverse childhood events. 26 of them have had one adverse childhood event. 16 have had at least 2 adverse childhood events. 10 of them have had 3 childhood adverse events, and about 12 have had 4 or more adverse childhood events. And so some of the things we've learned from looking at this study is we know that ACEs are common, right? These adverse childhood events are common. Nearly 2/3 of adults have had at least one. And we know that ACEs don't occur alone. So if you've had one adverse childhood event, there's an 87% chance that you have 2 or more. It's more likely that you have more than one than that you have one. And if we're looking at a population level, it doesn't matter which of those ACEs a person has. And we see that the harmful consequences are the same. The number of ACEs matter, but which one doesn't. So, as we're looking at that list earlier, some of you might have been thinking, yes, physical abuse and sexual abuse, those are very serious. Yes, living in a war zone, of course, but losing a parent to the mom and dad getting divorced, that's a pretty common thing. It's not that serious. What we know is that our brain can't distinguish one type of toxic stress from another, and all of the ACE categories have some evidence that they are toxic stress and they have the same impact. Now, what is that impact? So on our overall well-being, this pyramid describes the understanding about the mechanism. So how do these ACEs influence our health and well-being throughout our lifespan? How does what happens in childhood lead to a whole host of other problems later on in life? So we know that adverse childhood events can disrupt an individual's neurodevelopment. It changes the way that our brains develop when we are experiencing these things as our brains are still developing. That disruption in our brain development can cause some level of social, emotional, and or cognitive impairment. So people who've experienced adverse childhood events think and learn and remember differently. We also know then that those impairments lead to a much higher risk of adopting health risk behaviors. So things like smoking, eating, unhealthy diet, sedentary lifestyle, all of those are much more likely when we've had adverse childhood events or experiences. And then we know that those health risk behaviors, they're called health risks for a reason, they increase our risk for disease, disability, and other, they call it social problems, but, other problems with incarceration, income, food insecurity, housing insecurity, et cetera, and all of those things lead to early death. And we know that as the number of ACEs increases, and the next slide will show a little bit of that in a graphic way, but as the number of ACEs a person has experienced increases, so does the risk of all of these things. All of these things have some evidence, some research linking higher numbers of adverse childhood experiences to higher risk of these things. So here's a graph that shows you a little bit how the number of ACEs can impact the risk or the prevalence. So the different colors on our bar graph represent the different numbers. So the dark blue is 0, the sort of reddish pinkish is 1, green is 2 adverse childhood events, purple is 3, and then that light blue is 4 or more. And you can see, so ischemic heart disease, you can see at 0, the prevalence is, almost 4% in the population. And at 4 or more ACEs, we're almost to 6% of the population. Looking at COPD, right, the risk for COPD for 0 ACEs is about 3. And I'm getting loose with these numbers here, but this is the graph we have doesn't allow a greater degree of specificity, but about 3. And if you have 4 or more ACEs, that's up to about 9. Right? And that makes sense, given that what we know about changes in our brain development, changes in our health risk behaviors. So one big factor in that is smoking. So if we looked at smoking rates, that might map very nicely onto COPD. The same for diabetes. In all of these, we see that as the number of ACEs goes up, so does the prevalence in the population of these health conditions, these chronic disease conditions. And looking at behavioral health, the trends are even more dramatic, right? So if we look at mood disorders, we go from 0 ACEs having us somewhere in the 17 or 18% prevalence. With 4 or more ACEs, we're above 50% prevalence in the population. Anxiety disorders, even higher. With 4 or more ACEs, we're at 70% of the population. Also substance abuse and impulse control disorders. So all of these are impacted by ACEs, and the number of ACEs increase the likelihood of having one of these conditions. So if you think about the populations you serve and the work that you do, how many of you, and this is a rhetorical question, so how many of you might see patients for any or all of these conditions? And be competent, that went the wrong way. And how many of you may see patients for these conditions or see patients whose care that you're trying to deliver in primary care is complicated by these conditions? So not only do they have do ACEs and these adverse childhood events have a huge impact on our on individuals and on population health type measures, they also have a huge impact on our work on a day-to-day basis. I think as the information is being shared and disseminated more widely, there's a growing recognition that whether you want to focus on trauma or not, trauma shows up at your clinics and in your patients. So at least a basic sort of understanding of it and a sensitivity to it makes a whole lot of sense if we want to be effective in our work. So creating a trauma-sensitive culture. We're going to talk a little bit about this, and then I am going to foreshadow for you that I'm going to want to hear from you some thoughts, reactions, and questions. So if you're thinking of questions or responses, reactions to any of this content, feel free to be entering it into the chat box as we go. I know for me as a participant, sometimes I have a thought, and then if I don't do something with it right away, it's gone by the time we get to the Q&A at the end. So we will open up the lines at the end for some Q&A, but the chat box and the chat feature is available at any point. So we hear a lot about trauma-informed care. This is our new sort of buzzword, trauma-informed care. So what does it mean to be trauma-informed? So a program, organization, or system that is trauma-informed is one that recognizes the impact of trauma and how widespread that is, and understands that there are potential paths for recovery for individuals to get back to a state of wellness and healing. A trauma-informed system also recognizes what does trauma look like when it shows up? What are some signs and symptoms that I might be seeing in the patients that I serve, and then also in the staff that I'm working with, in my coworkers, and in families and other people that are involved in the care that I'm providing. Also, trauma-informed systems respond to this recognition and realization by integrating knowledge about trauma into some of their procedures, practices, and policies. And with an eye toward actively resisting re-traumatization. So are there things that you can identify within your system that might be inadvertently re-traumatizing individuals who you're providing care to, and how could we change those things? I do want to note that being trauma-informed is different from and distinct from offering trauma-specific interventions or treatments. I think a lot of the materials out there, at least some of the materials that came out first around trauma-informed care and trauma-informed systems and organizations, really looked specifically at behavioral health organizations and helping them increase their capacity to provide treatment and intervention for trauma. That's not a realistic expectation necessarily for primary care. In primary care, we generally don't have the capacity to treat trauma. Somebody shows up for I've got 7 minutes to meet with that person, I'm probably not going to be delving into any trauma treatment. But I can be trauma-informed and very sensitive to the role that trauma may be playing in my interaction with that individual. And that's what some of the newer materials are starting to come out around trauma-informed care in primary care systems, and that's what they focus on. But I do want to point that out because as someone, looking at it from a trauma-informed lens, 5-7 years ago, that was very frustrating for me to think, well, that's not our role, but what can we do? So there are some things, and we'll look at a few things now in a minute, that really could make sense in a primary care setting. So there's 5 principles of trauma-informed care. We want to create safe spaces, right? So can we pay attention to both, physically, what might help a person feel physically safe and what might help a person feel emotionally safe in our setting. Transparency and trustworthiness. So providing enough information about what's happening and what's likely to happen next to individuals. Now, I can tell you in the healthcare system, sometimes that is really hard. I often give the example that my children's pediatrician has that we can schedule our appointments online, through our electronic health records. So I can go in and I can indicate the reason for the visit, and, it gives me a whole host of different appointment days and times that are available, and I can, specify that and schedule an appointment and get an email reminder. And all that tells me is what time the appointment starts. I don't know until I show up that day with my kids in tow if I'm scheduled for a 10-minute appointment, a 20-minute appointment, a 2-minute appointment, which I'm usually not scheduled for, but sometimes it feels like that's all the time they have for you that day. So having full and accurate information up front would be really helpful for me as someone who's really trying to be a responsible utilizer of healthcare, and I want to come ready for the visit, but how can I get ready if I don't have that transparency? Now, trustworthiness is about, doing what you say you're going to do, and transparency is about saying what you're going to do. We also, another key principle in trauma-informed care is choice. So how can we, I think that bullet got duplicated there, but how can we offer a menu of options to people whenever possible and let people have an active role in deciding not just, the course of their treatment in perhaps like a shared decision-making type of model, but are there ways that we could offer them some choices? Today I want to collect some history from you. I want to talk about how things are going, and we have to do a brief physical exam. Which of those would you like to do first? Those types of situations can support a sense of control for the other person. And the fourth principle of trauma-informed care is collaboration and mutuality, which really talks about our relationship and the recognition that our relationship is where healing happens. And we want to share some of that power, control, and decision-making with the other person, with the patient. And empowerment. So we want to recognize, validate, and build on the patient's strengths and encourage them to actively participate in their own care. So what does that actually look like, though, in these general healthcare settings, particularly in primary care? So one thought is that a lot of organizations are beginning to screen for trauma. So identifying those patients who have experienced trauma up front and having that knowledge can help us better tailor our care for that individual. It's important to note, though, that you shouldn't just sort of run off and start screening without some understanding about what are you going to actually do with the information. How will this information shape your actions with that individual? What's going to be different based on what you find out? And if your answer is, well, nothing's really going to be different, then screening may not be the first place you want to start. Another approach is to think about trauma as sort of something that we can apply these universal precautions around, right? So we think about universal precautions for infection. We think about just assuming that everyone has a likely potential to have an infection that can be spread, and so we act accordingly. There are certain things we do just as a standard for everyone, whether we know up front that they have an infection or not. And so patient-centered care strategies can really help everyone, and then they can particularly provide benefit to those trauma survivors. So some things, get down to the specifics, some things might look like some actual concrete steps to create a safe physical and emotional environment. Thinking about the safety of parking lots, common areas, how accessible are bathrooms, how well lit are they, how well lit are your entrances and exits. Thinking about the music that's played, is it calming? Offering a variety of comfortable and soft seating options. Okay. Having clear and welcoming signage. That is, as someone who gets lost a lot, I'm navigationally challenged. That's always welcome for me, clear signage, so that a person just has a little more control and feels like they can know where they're going easily. Also having posters or printed materials about trauma that encourage talking, your healthcare team wants to know about your needs, things like that. And then thinking about staff. Are they running around and, getting very worked up on busy days and presenting this atmosphere of rush and chaos, or are they maintaining a deliberate, unhurried pace even when the office is busy? And then if a patient hesitates about something, being prepared to ask and offer the option to discuss things privately. And all of these come from this toolkit that's linked here, which is specifically developed for campus health centers, but it has a lot of great resources on how to create safe medical visits. So other things we can do to create safety when we're needing to have a physical exam, describe what touch will be involved up front, and then repeat that as it goes along during the exam. Be flexible and open to discussing clothing requirements and collaborate on an agreeable solution. Maybe they don't need to gown if they're comfortable with you, moving their shirt around in certain ways, then they don't have to change out of their clothes and into a gown. That's just one example. Encouraging patients to ask you to slow down, pause, or stop as needed. Asking for permission before any touch, and then again as you move to other body parts. And then watching for signs of distress. Is the person's breathing getting more shallow or rapid? Are they, have you noticed any change, do they become more pale or more flushed? Any fidgeting, things like that. And just being able to and ready to ask for ways to make the process more comfortable and ask the patient if there's anything else that you should know or that they want to share with you before you proceed. A lot of these things you'll note are just general, it's good care. It's just good care and it's the way we should be behaving anyway. But reminding ourselves of these and knowing that these can really help better serve our patients who've experienced trauma can be very beneficial. So what do you do when someone does get triggered in your clinic? Gosh, I'm not a trauma expert, but now I've got somebody who's, seems to be really not regulated well, and I need to help them come back to a normal state. So there are some very simple grounding techniques that we can encourage people to use. They may be aware of them, and we may just be reminding them of this. Or this may be something new. One of them is called the 5 senses. So encouraging someone to look around the room and identify, and they can either say it out loud or just identify it in their mind. 5 things you can see, or 5 things you can feel or touch. 4 things you can see. 3 things you can hear. 2 things you can smell. And 1 thing you could taste. Now, you're not supposed to go and smell and taste and hear and see and touch all those things, but just looking around the room and identifying those can help orient the person. What it does is it brings a different part of our brain online, and so it sort of helps our brain shift out of that very primal trauma response and into a more cognitive-based logical response. Also, counting or saying the alphabet is another one. We can also, if someone does get triggered in the course of our care with them, we can normalize that by just commenting that, healthcare interventions commonly trigger emotional responses. I wouldn't necessarily label it as a trauma response unless that's a shared known thing between you and the patient, but just, these, physical exams can really have people feeling emotional sometimes. And just normalizing that for the other person can help create, number one, a positive relationship between you and them and a positive connection, and also a sense of safety and security. And then if someone does get triggered as in the course of the care that you're providing, we want to be sure to be following up with that person, whether that's, asking them to schedule another appointment in a short period of time or even just doing an outreach phone call with them. So we've gone over some common definitions of trauma, some key concepts. We've talked a little bit about the Adverse Childhood Experiences study and what we know about the impact of adverse childhood experiences. And we've talked a little bit specifically, what is trauma-informed? What does it mean to be a trauma-informed organization? And what are some specific things in the general healthcare setting or the primary care setting that we can do, that we can implement to be more sensitive and responsive to reactions that may be based in trauma, without going on to get any more additional, sort of specialized training in trauma. There are a lot of resources out there. Like I said, this is a pretty hot ticket topic right now. There's been a lot of initiatives around increasing the amount of trauma-informed practices that are out there, and what we want to encourage you to do is just move forward with an open eye toward this. And I also think that the idea, a lot of the stigma that patients who might be experiencing mental health or substance use conditions, whether we're seeing them in a specialty care treatment setting or in our communities or in primary care, it helps to have a recognition and an understanding that a lot of times these people are experiencing those things because a lot of things have happened to them that were very traumatic in their life. As you saw, sort of a connection between substance use, mood disorders, and childhood trauma is very strong and there's a very strong link there. So we want to recognize that I started this presentation with asking you to look at the small child and how compelled would you be to help her, looking at someone more in the middle of their life and a little bit toward the later of their life. Unresolved trauma can be a through line in someone's life that really looks like just a cascade of more and more difficulties as their life develops. So if someone hasn't had access to resources to help heal from that trauma, they may very well present in ways that make them hard to want to care for in our primary care setting. These are often the patients that we think of as challenging, more difficult, and the harder patients to care for. So for me, at least, having that understanding of how likely it is that the individual in our last picture on the slide was once the individual on the first picture of that slide really helps me keep oriented and feel positive about providing care to patients who sometimes don't give us a lot of good vibes when we're in a care provision setting with them. So at this time, I am going to open it up. We've got about 5 minutes left for questions. So again, feel free to type questions or comments in the chat box, or I'm going to have the operator remind you of how you can request that your line be open for comments or questions.
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. There will be a slight delay before the first question is announced. If you're using a speakerphone, you may need to pick up a handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Waiting on standby for phone questions. And I'm not showing any phone questions at this time.
So one question in the chat box asks, where will we be getting the survey and post-test for the Michigan Social Work CEs? And actually that answer for that is the same for all CEs. Following this, the end of this webinar, we will be providing a list of who attended to our continuing ed department, and an email will be going out. So and this is a reminder, if you're listening as a group, Please, 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 I'll go back to the slide with the email on it, but make sure that you send an email to our continuing ed department with the names and emails of everyone who was listening on your line so that everyone can get their survey to complete. Let me go back to the evaluation link. Oh, it's not on there.
Mia, this is, everyone, this is Julie. The place to send that to is continuing-ed@medistar.com.
So I'll chat that email out to everyone as well. And we have another question, which is, will there be a playback on this or a way to access the slides? If you go to the event registration page where you initially signed up, there is a PDF of the slides available there that you can download. And this will be available on the Lake Superior Quality Innovation Network YouTube channel. Sometimes that takes about 2 weeks to get that up and posted on the channel. So if you're looking for the playback of it, if it's something you want to make sure you get the link to, feel free to email me directly. And when that link is available, then I can send that out to you. So my email is on the last slide, which I'm not on anymore. So I just emailed out the link for if you have individuals who were participating and in a group, send your list of people and their emails to that email address that I just put in the link. And if you have questions or if for some reason you don't receive the email, feel free to contact me, and my information should be on the screen now. And the slides are available. If you go to the event registration page on the Lake Superior Quality Innovation Network events page, they're available and can be downloaded there. We are now at time, so I just want to thank everybody for joining, and I don't know, Julie, if you have any other closing remarks.
No, Mia, I just would like to remind everyone you did a great job of just telling them this, that the recorded webinar should be available in about 2 weeks on our LSQIN YouTube channel. And I just really want to thank you, Mia, for sharing this valuable information. And thanks for everyone who was able to join our webinar today.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.